Hi everybody, and welcome to our module on the shoulder and elbow. The shoulder is an example of a ball and socket joint. It's also called the glenohumeral joint. The reason it's called this is because it's a joint between the glenoid, which is a fossa of the scapula bone, it's shown right here, and the humerus, which is the bone of the upper arm. And there are three bones that participate in the shoulder joint. Those are the clavicle, the scapula, and the humerus. They're all shown in this picture at the bottom of the screen. This is the humerus in the arm, this is the scapula, and the clavicle is shown here. I'll briefly go over the movements of the shoulder. So flexion is to move your arm forward and upward in front of your body, and extension is to move it backwards as shown in this image. Abduction is to move the arm away from midline, and adduction is to move it towards midline. And then finally, rotation can be either lateral or medial of any joint, including the shoulder. So lateral rotation, which is also called external rotation, means to twist a joint away from the body. Medial or internal rotation is to twist a joint towards the midline of the body. The most important thing about the shoulder for you to know for the Step 1 exam is the rotator cuff. The rotator cuff holds the shoulder together. It's formed by four muscles that surround the joint whose tendons come together to form the rotator cuff. Those four muscles are the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. If you look at this picture at the bottom right side of the screen here, this muscle here is the supraspinatus, and you can see it wrapping around the shoulder joint. Its tendon contributes to the rotator cuff. So do the tendons of the subscapularis and the teres minor. The infraspinatus is not shown in this picture. So the job of the rotator cuff is to draw the humerus head into the glenoid during abduction. Abduction means moving the arm away from midline. So when you do this, your shoulder would pop out of the joint if not for the rotator cuff holding it in place. So rotator cuff problems are common clinical problems. Tendinitis of the rotator cuff is a common cause of shoulder pain, and as you can imagine, it classically leads to pain with abduction of the shoulder. There can also be tears in the rotator cuff tendons. These tears can lead to the inability to abduct the upper arm. So now we'll talk about the four muscles of the rotator cuff individually. I'll start by talking about the supraspinatus. And the supraspinatus gets its name because this muscle is found above the spine of the scapula. This is the scapula here. This structure shown in red is the spine of the scapula, and as you can see in red in this picture on the right side of the screen, the supraspinatus is found above the spine of the scapula. Its job from a mechanical point of view is to initiate abduction of the shoulder. So when you move your arm out to a 90-degree angle at your shoulder joint, the first 0 to 15 degrees are accomplished by the supraspinatus muscle. The main abductor of the arm is the deltoid. We'll talk more about that later. It moves your arm from 15 to 100 degrees. But to get abduction going, that is done by the supraspinatus. It's innervated by the suprascapular nerve. The suprascapular nerve also innervates the infraspinatus muscle. We'll talk more about this later. And the reason I'm talking about the supraspinatus first is because it is the most common rotator cuff injured muscle. The reason the supraspinatus is commonly involved in rotator cuff injuries is because of impingement. The tendon of this muscle can become compressed between the head of the humerus bone in the upper arm and the acromion process of the scapula. Shown in red at the top right side of the screen is the acromion process of the scapula, and the tendon of the supraspinatus runs beneath this and above the head of the humerus, and therefore the supraspinatus can become impinged in the subacromial space, which is the space below the acromion. When it becomes impinged or compressed, this leads to tendinopathy and inflammation, or it can even lead to a tear. And this commonly occurs in people who use their shoulder a lot. So swimmers and throwers are often lifting and lowering their arms, so they can develop a supraspinatus tendon injury. This is sometimes called swimmer's shoulder or thrower's shoulder. And here's another picture just to make this point very clear. This is the acromion of the scapula. It's this bony structure right here. This is the head of the humerus right here. And here we have the supraspinatus muscle and tendon inserting on the humerus right here. You can see that it runs between the acromion and the head of the humerus, and therefore it's vulnerable to impingement. There is a clinical maneuver used to test for supraspinatus injury. It's called the empty or full can test. So to perform the empty can test, the patient puts their arm out in front of them at 90 degrees abduction and 30 degrees in front. They put their thumbs down, so this is the position you would have your hand in if you were trying to empty a can of soda. The examiner then pushes the arms down against resistance, and if there is pain, this is a positive empty can test. And the full can test is very similar, but the patient puts their thumbs up as if they were holding a full can of soda. Next, we'll talk about the infraspinatus muscle. This muscle is named because it runs below the spine of the scapula. It's shown in red in the drawing on the right. The spine of the scapula is here, just to remind you what that structure is. The infraspinatus muscle assists in a couple of maneuvers at the shoulder joint. It assists in external rotation of the arm and also abduction of the shoulder. The innervation to the infraspinatus muscle is via the suprascapular nerve, the same nerve that innervates the supraspinatus muscle. And this muscle or tendon is commonly injured in overhead throwers or pitchers. Among pitchers, the most common rotator cuff injuries are either the supra or infraspinatus muscles or tendons. And it's difficult to assess the infraspinatus in isolation. There isn't a version of the empty or full can test that isolates this muscle or tendon. The third muscle that contributes to the rotator cuff is the teres minor. This muscle assists in external rotation of the shoulder joint and also adduction of the shoulder joint. If you look at this picture on the screen, the teres minor is muscle number 6 here. You can see it attaching to the shoulder joint, and its innervation is via the axillary nerve. And the final rotator cuff muscle is the subscapularis. It's shown in this drawing on the screen here. This muscle gets its name, as you can imagine, because it's found below the scapula. And this muscle plays a role in internal rotation of the shoulder or the arm. So if you put your elbow at a 90-degree angle with your fist out in front of you, if you move your fist towards your abdomen, that is internal or medial rotation of the shoulder joint. If you swing your fist away from the midline, that is lateral or external rotation of the shoulder joint. And the innervation of the subscapularis muscle is via the upper and lower subscapular nerves. In another video, I talk about the brachial plexus, but I just want to mention here that all of the nerves that innervate the rotator cuff muscles come from the brachial plexus. Here is the subscapular nerve here, the axillary nerve is here, and the upper and lower subscapular nerves are shown here. Let's briefly talk about shoulder movement. So when you move your shoulder out in this direction, that is abduction, and you should know the muscles responsible for this action. So first of all, the deltoid is the primary shoulder abductor up to 90 degrees. This is the deltoid muscle shown on the screen here. And you may know that bodybuilders develop huge deltoid muscles by lifting heavy weights out laterally. That is abduction of the shoulder, and that works the deltoid muscle, which is innervated by the axillary nerve. Now there are other muscles that participate in abduction of the shoulder. As I told you before, the supraspinatus is important for initiating abduction for the first 15 degrees. And then two other muscles, the trapezius and the serratus anterior, help with abduction beyond 90 degrees. But basically, if you want to think of the main muscle that moves your shoulder out laterally, just always remember that the deltoid performs that maneuver. The shoulder joint can become dislocated, meaning the humerus moves out of the glenoid fossa. This happens from trauma. Usually it is an anterior dislocation of the humeral head, meaning the head of the humerus moves forwards towards the front of the body. This usually happens when there's trauma to an arm in a vulnerable position, and the most vulnerable position is when the arm is abducted, externally rotated, and extended. And if you think about it, this is the position that your arm is in when you're shooting a basketball or throwing a football. So this commonly happens when there's trauma while a player is trying to make a basketball shot or when a quarterback is tackled while throwing a football. And one thing you should be aware of in terms of anatomy of shoulder dislocations is that they commonly result in damage to the axillary nerve. That's because the axillary nerve runs below the humeral head and wraps around the neck, so it can become injured in an anterior shoulder dislocation. This will result in loss of sensation over the deltoid. Just always remember that the deltoid muscle is associated with the axillary nerve. That includes sensory function over the deltoid muscle, and in addition, there will be weak abduction because, as I told you previously, the deltoid is a very important abductor of the shoulder joint, although in reality the shoulder is usually too painful to move and it's difficult to test for abduction in a shoulder dislocation. Humerus fractures can also occur from trauma. They're common in the elderly when patients suffer falls. They often occur in the proximal humerus, meaning the humerus at the top near the shoulder joint. The blood supply to this portion of the humerus is from branches of the axillary artery, and fractures can disrupt this blood supply, and that makes the head of the humerus vulnerable to avascular necrosis. In addition, there are a number of nerves near the proximal humerus. Many branches of the brachial plexus are found in this region. And once again, the axillary nerve, you can just always remember, is found near the shoulder joint, and this can be damaged from a humerus fracture that occurs proximally, and this will lead to loss of arm abduction, once again from that deltoid muscle. Now let's talk about the elbow joint. This is a joint between three bones, the humerus in the upper arm, shown here in this picture, and the radius and ulna, which are bones in the lower arm, also both shown here in this picture. And the main thing about this joint is that it's prone to overuse injuries. So golfers and tennis players who bend their elbow a lot often have injuries at the elbow. And the main overuse injury that occurs at the elbow is called epicondylitis. So if you look at this drawing of the humerus bone on the screen here, At the bottom of the bone, which is where the elbow joint is, there are two bumps called epicondyles. One is medial, that's the medial epicondyle. The other is lateral, that's the lateral epicondyle. The lateral epicondyle is the bony origin of the extensors of the wrist, and the medial epicondyle is the bony origin of the flexors of the wrist. So epicondylitis is pain that occurs at one of the epicondyles from overuse. It's actually somewhat of a misnomer because there isn't a lot of inflammation. It's a form of what's known as chronic tendinosis. There are few inflammatory cells, but there's usually disorganized tissue and vessels, and it causes pain, and because it causes pain, it's called epicondylitis. So the clinical presentation of epicondylitis is pain in either the medial or lateral elbow, depending on which epicondyle is the problem, and the pain is classically worse with repetitive movements at the elbow joint. Lateral epicondylitis is also called tennis elbow because it happens more commonly among tennis players. In this condition, there is tenderness over the lateral epicondyle of the humerus and also the proximal portions of the wrist extensor muscles. Remember, the wrist extensors insert into the lateral epicondyle, so the proximal portions of those muscles right near the lateral epicondyle will be tender. In addition, if you ask the patient to extend their wrist while you resist that motion, that will increase pain at the elbow. And once again, this is because the wrist extensor muscles insert into the lateral epicondyle. And in contrast, medial epicondylitis is called golfer's elbow because it's more common among golf players. This presents with tenderness over the medial epicondyle, and the maneuver that is painful in this situation is wrist flexion because those wrist flexors insert into the medial epicondyle of the humerus. Nursemaid's elbow is also called radial head subluxation. A subluxation is a partial dislocation, and in this condition, there is a partial dislocation of the head of the radius bone. If you look at this picture on the bottom right side of the screen here, we have the humerus bone in the upper arm and the ulna and the radius in the lower arm. The radius sits beneath a ligament called the annular ligament. So if the radius is yanked in this direction, the head of the radius can move outside of the annular ligament. That's called a subluxation. This condition is caused by axial traction on a pronated forearm. Basically what this means is that the arm is pulled when the arm is extended at the elbow, and this commonly happens to children when they are yanked by a nursemaid. That's why it's called nursemaid's elbow. When this occurs, the annular ligament will slip over the head of the radius and the ligament will become trapped in the radiohumeral joint, and that is nursemaid's elbow. A supracondylar fracture is a fracture just above the condyles of the humerus, so it's a fracture in the lower part of the humerus bone in the upper arm. And this is the most common pediatric elbow fracture. It often happens when a child falls on an outstretched arm. And this is an X-ray showing a supracondylar fracture. You can see how the humerus is shattered basically just above the elbow joint. Because this is the most common pediatric fracture, you should be familiar with it and the relevant anatomy for the Step 1 exam. So first of all, you should know that the brachial artery may be injured. It runs just above the elbow joint over the humerus. In addition, the median nerve travels with the brachial artery, so the median nerve can also be injured by a supracondylar fracture. And in fact, injury to the brachial artery and the median nerve together is the most common neurovascular injury associated with a supracondylar fracture in a child. Now, the radial and ulnar nerves also may be injured. The ulnar nerve travels under the medial epicondyle. So if the fracture is more medial, it can damage the ulnar nerve. The radial nerve wraps around the humerus laterally, so if the fracture is more lateral, it may injure the radial nerve. Here's a picture just to make the anatomy very clear in your mind. The brachial artery is shown here. It runs over the humerus bone and right across the middle of the elbow joint. It then branches into the radial and ulnar arteries in the lower arm. On the left side of the screen is the humerus bone, so the median nerve runs right down the middle together with the brachial artery. The ulnar nerve runs more medially and the radial nerve runs more laterally. And that concludes our module on the shoulder and elbow.